In order for you to be able to treat your patient with heart failure, you must understand exactly what is the mechanism of heart failure and what are the neurohormonal changes that follows this mechanism. So, as you know that the blood comes back from the lung filled with oxygen through the pulmonary veins and into the left atrium, from the left atrium to the left ventricle, and the left ventricle or the ventricles in general, they pump the blood into the aorta and or the pulmonary artery. So let's talk about the left ventricle pumping its blood through the aortic valve into the aorta. What happens exactly with the failing heart is that the heart is not able anymore to eject enough blood into the aorta. So there will be, in the failing heart, a decrease in the ejection fraction. The heart that has a decreased ejection fraction will not be able to maintain good cardiac output. So decrease in the cardiac output. This decrease in cardiac output will be reflected on what? Will be reflected on the pressure. So there will be a drop in the blood pressure. This drop in the blood pressure, actually it is sensed by the body and the nerves in the body through the carotid baroreceptors that are present in the aortic arch and the carotid bulbs in the internal carotid arteries. The carotid baroreceptors will send signals to the brain via the vagus nerve and the glossopharyngeal nerve, telling the brain that the brain, please, the blood pressure has dropped and we need to do something regarding that. And the brain, what will do? It will release the norepinephrine. And this norepinephrine that is released is the first neurohormonal changes with excessive amounts of norepinephrine released from the brain into the circulation. The norepinephrine in turn will act on the beta receptors and the alpha receptors, and we will take them selectively as the beta 1 and the alpha 1 receptors. The beta 1 receptor, when the norepinephrine acts on it, it has two effects. One effect on the heart and the other effect on the glomerulus. On the heart, it will increase the heart rate and it will increase the contractility. So thus increasing the heart rate to maintain a better cardiac output and to increase the contractility of the heart in a way to decrease the drop in this blood pressure. Thus it has a chronotropic and an inotropic effects. And on the glomerulus, it will really increase the release or stimulate the release of the renin enzyme. While working on the alpha receptors, it works on two places. They are actually the alpha receptors, on the blood vessels. So they act on the arteries and on the veins too. They cause vasoconstriction, direct vasoconstriction of the alpha receptors, alpha 1 receptors from the norepinephrine. So by causing vasoconstriction, they increase the blood pressure in the arteries. In the arteries, they tend to increase the blood pressure by causing arterial vasoconstriction, and when they act on the veins, causing vasoconstriction of the veins, what will they do? They will increase the venous return to the heart in order to increase the blood flow coming back to the heart, then that is going to the ventricle and that is pumped back to the systemic circulation. So vasoconstriction in the arteries and vasoconstriction in the veins in order to increase the preload and increase the afterload. By increasing the venous return, we increase preload. And by causing vasoconstriction in the arteries, we increase the afterload. Also, it acts on the blood vessels that supplies the kidney, which is the renal artery. It causes vasoconstriction in the renal artery. And by causing here a vasoconstriction in the renal artery, you decrease the blood flow to the kidney. So you decrease the filtration rate. When you decrease the filtration rate, you maintain the fluids in your body. That's how the norepinephrine, it acts on the beta 1 and the alpha 1 receptors, in summary, on the heart by increasing the heart rate and contractility, on the glomerulus by increasing the release of the renin, and on the blood vessels, arteries and veins by causing vasoconstriction to increase the preload and increase the arterial load and decrease the renal blood flow by decreasing the filtration rate. Then here comes the role of the renin. The renin that is released from the glomerulus acts on the angiotensin gene that is produced by the liver, and the angiotensin gene is converted to angiotensin. Renin acts on the angiotensin gene to form the angiotensin 1, and the angiotensin 1 is converted to angiotensin 2 through the angiotensin converting enzyme that is released from the lungs. And the angiotensin 2, now it has the two effects on the adrenal gland and the blood vessels as well. So let's concentrate on the angiotensin 2. It acts on the blood vessels, also the arteries and the veins. It causes vasoconstriction, thus further vasoconstriction of the blood vessels to increase the arterial load and to increase the preload, and it also acts on the adrenal gland to increase the release of the aldosterone hormone. This aldosterone, it works on the kidneys, on the distal convoluted tubules. Here it acts on the distal convoluted tubules. This is one of the MCQ questions. All what I have mentioned are MCQ questions that you should be aware of. So aldosterone acts on the distal convoluted tubule to enhance more sodium and water production, and it will act on the brain to stimulate also the brain to release the antidiuretic hormone or vasopressin. So they like it, this question. They ask all of the following are the sequelae of neurohormonal changes of heart failure, except they say increased release of antidiuretic hormone, which is the vasopressin, the aldosterone, angiotensin 2, angiotensin 1, the renin, the norepinephrine, all of them, they are increased. So what is the end effect of this increase? The end effect, increasing the preload, increasing the afterload, increasing the heart rate, increasing the contractility, and I am maintaining good blood volume and maintaining good volume inside the blood vessels. Thus, I'm putting the patient in a volume overstate condition that at the end it will result in remodeling. What is remodeling? This increased volume of blood in the ventricle will result in myocardial cell hypertrophy, apoptosis, necrosis, and fibrosis. Thus, the heart changed from this shape to this shape, from a normal heart to a heart that is stretched from the volume overload and exhausted from the increased afterload and from the tachycardia. It is stretched and it dilates at the end, and this process is called the remodeling. So in treatment, I need to prevent this remodeling process. This is the aim of the treatment of heart failure. In this slide, I will, let's say that the heart is two halves. It is the left heart and the right heart, from the left ventricle and the right ventricle. So we will talk about a left heart and a right heart. If the left ventricle fails to pump the blood into the systemic circulation, into the systemic circulation, so the blood will be and the pressure will be reflected back in the pulmonary veins and will be reflected to the lungs. So the left heart failure, it will result in pulmonary congestion. While in right heart failure, when the right heart here fails to pump this blood up back to the lung, so the pressure will increase here and it will be reflected back to the liver, to the GI tract, to the lower limbs, and it will result in signs and symptoms of right failure with lower limb edema and ascites.